Pleasure to be here with you guys this morning. And I am going to talk about the diabetic foot in 2022, how we can cover the basics, but also using modern medicine. And a lot of this is going to focus on perhaps a systematic way of thinking and approaching the diabetic foot. So as Dr. Viswanathan said, I'm a fellow faculty in podiatric medicine at the Royal College, chief of podiatry at UT San Antonio, president of the American Board of Podiatric Medicine, and also the associate editor of the Journal of the American Podiatric Medical Association. Soaring diabetes rates wake the prosthetic industry. This was the front page of the business section of the Los Angeles Times, not the health section, but the business section, talking about the business of amputations in the United States. And our goal is to put these people out of business, I guess, to help reduce the number of amputations and prosthetics that are necessary. So we've written a lot about the natural history of how someone with diabetes will end in an amputation, and it's not a single step process. I know you may hear patients just like I do, I have diabetes, I'm going to get an amputation. But in fact, there are several steps that occur in between those two endpoints. It starts with neuropathy. After 8 to 12 years, patients with diabetes tend to develop neuropathy. Then repetitive stress will cause an ulceration. They may or may not have vascular disease in combination with this, but it's almost always the infection, which is the coup de grace, or the final blow, that leads to the amputation. We call this the stairway to an amputation. Our goal is to de-escalate people. So when you have an infection, we want to reduce their risk of an amputation by taking care of the infection. If there's vascular disease, we treat the vascular disease. And so in order to do this with just the sheer numbers of patients, and I can tell you, I've been at UT, I'm sure all of you are familiar with UT, having had in San Antonio, Harkless and Lavery and Armstrong here, among many, many others. But in order to deal with the sheer number of patients, which last year we had 11,034 new patient referrals with diabetic foot problems into our clinic, we had to develop urgency pathways. And this really helps us understand how quickly to get somebody in and how often to see them, because we have to basically triage our own time and focus on the people that are most important or most at risk. So this is the overarching pathway that we've created, where we see that people really fit into only 13 different categories. They're either on one side of the spectrum, which you can see over here on your left. They're a patient with diabetes that's coming in for screening. And this is all FRC, means foot risk category. These are the UT foot risk categories. And then we have patients that have active problems, and they're over on the left side of or the right side of your screen. And these are people that have a hot spot. We'll get into that in a moment. Or they have a diabetic foot ulcer, which is either uncomplicated, complicated by infection, complicated by vascular disease. And so this helps us to say, okay, where is this person on the spectrum? Do they need to be admitted into the hospital? And how quickly do we act here? So I'm going to go through some of these and just kind of give you our worldview from South Texas. So let's focus on the left side of the algorithm, or the urgency pathways, and that's the screening side. And so these are our patients that come in for comprehensive diabetic foot risk examinations, and then we categorize them according to the UT foot risk category, and so the UT diabetic foot risk category has been published numerous times. It's been adapted by also numerous organizations, including the International Working Group on the Diabetic Foot. It was first written by Edgar Peters and Larry Lavery. And there we go. It's weird when you do a zoom and like everything's in your screen, you can't see anything. So it was first written by Peters and Lavery. And what you see here in red in this box is are the different risk categories. So group 0, 1, 2, and 3. and the odds ratios for each of those categories in the likelihood of developing an ulceration over the next, in this case, it was about 18 months. And so I've summarized that in a bigger table that's easier to read for you. And that's right here. So this is risk of ulcer and risk of amputation. So if you're risk category 0, these are patients that have diabetes without loss of protective sensation. The risk of getting an ulcer over, I'm sorry, this was over 3 years. The risk of getting an ulcer over 3 years was 5.1%. If you are risk category 1, the risk of getting an ulcer, these are patients that just, they have diabetes, but they have loss of protective sensation in addition to that. So not just neuropathy, but loss of protective sensation. The risk of getting an ulcer is 14.3%. Risk of amputation, still 0 in this category. And then loss of protective sensation plus deformity, which Dr. Wukic just spoke about. Risk of ulceration over 3 years, 13.3%. Risk of amputation, 2%. Now, this category does include PAD. So when you look at most risk category 2s, PAD is added to this. These numbers are probably different. So don't, when we look at the risk of ulceration and risk of amputation, we added a whole new group of people in here. So these have to be recalculated. But then we have risk category 3, which is the highest risk. And those are patients that have a history of pathology. They have had a history of a diabetic foot ulcer, a history of Charcot, a history of an amputation already. In 3 years, 65% of them ulcerated. And in 3 years, 25% of them received an amputation. So this is data from South Texas. So again, as I said, this has been adapted by numerous organizations, including the International Working Group. This is the ADA's risk categorization. And again, they kind of break it into those that have active pathology. This was based on referral criteria for people taking care of patients with diabetes. So obviously, those that have active pathology need an urgent referral. And then we have high, moderate, low, and very low. So these are the same risk categories as the UT and International Working Group here. So while we're talking about risk categories, let's just talk briefly about the prevention of foot ulcers before we get into the treatment of them. So we have somebody in one of these risk categories. We know that how ulcers form, the critical triad, neuropathy, deformity, trauma. But it was Paul Brand who made these discoveries in India in leprosy that connected neuropathy to ulceration, and also described how the cardinal signs of inflammation are that a foot gets inflamed before it breaks down, an ulcerative area. And these cardinal signs of inflammation, while pain is no longer a good warning sign, the other cardinal signs might be, and that would be redness, swelling, and heat. But out of all of those, the one that is most easily and I guess reliably measured is heat. So we can use things, and this is where the modern part comes into the modern medicine. We can use things like thermography to look at the heat signatures of our patients' feet. Now, this camera that's over on the left, this was a camera we got in a grant. It's a Fluke. It cost $15,000. That's not really feasible for most diabetic foot clinics. But now look over on the right. This camera, this one is made by FLIR, but Fluke and FLIR kind of are competitors in the infrared thermography space. So they both have ones that are made for your iPhone or Android. This one costs less than $300. So for less than $300, now you have a tool that can hook up to your iPhone and give you pretty specific images here on heat signatures for patients' feet, things that you not only may not be able to see with the naked eye, but you may not be able to palpate. There have been studies that have looked at physicians being able to palpate the differences in temperatures between feet. You might feel it and say, oh, I feel a difference here, or I don't feel a difference. But it wasn't until about 8 degrees difference that physicians were reliably able to palpate a difference in temperature in feet. So when we look at deformities, we know that there's increase in pressure under those deformities, and that increase in pressure leads to inflammation. And you can see with something as simple as this camera that how easy it is to be able to identify that hot spot, and this can help drive your offloading and also your patient education. So we have a lot of tips on how to do this. There are, my email address is at the end. If you're going to buy one of these, send me an email and I'll give you some tips on how to make this your experience using one of these cameras a little bit better. You can see I have a drape in the background on this one. And this drape is just a paper chuck. You have to separate the patient's heat signature of their body, which always gets in the background if you don't separate this, and it'll screw up your whole image. So send me, if you're going to buy one of these, send me an email, and I'm happy to walk you through some of our tips and tricks, and we should actually publish it soon. So you can also use thermometry, which is different than thermography. You get an image with thermography. Thermometry, you get a point of temperature. Now, thermometry has been studied and found that it can predict ulcerations in advance of the ulcer occurring. So the first thermometry study that was done by Lavery found that patients that used a dermal thermometer had a much lower ulceration rate over 18 months than those that didn't. So there was a 12% ulceration rate. These were in risk category 3 patients. So the patients at highest risk already, 12% ulceration rate over 18 months, no thermometer, 4.7% ulceration rate over 18 months with a thermometer when they were just warned that they were going to break down. Now, especially with the pandemic and our, it's not necessarily that these things were not available before the pandemic, but they just became much more practical during the pandemic. So remote patient monitoring has become a big deal so that you don't have to see somebody in person. And in fact, these are just wonderful devices to use at home. This was a study that was done by Bob Freiberg looking at the accuracy threshold, sensitivity, and specificity based on the temperature difference. So you want to see what we usually say 2.5 degrees centigrade or 4 degrees Fahrenheit. And when you see these different thresholds that were done in this study, one from the earlier Lavery study and 3 from this study, you can see how the sensitivity and specificity changes in the ability for it to predict an ulceration. So just look up there at the asymmetry threshold. This is looking at the same point on both feet, the asymmetry between the temperatures on the inflamed side versus the uninflamed side. So let's say a big toe, looking at the big toe on one side, if it's 2.22 degrees different on average centigrade, then it is then the sensitivity for picking up an ulcer in advance 97%, but specificity very low. This makes sense. Anything can increase. You can get gout, you can get an infection, you can have just arthritis. So the specificity is low, the sensitivity is very high. So the key is finding a space where the sensitivity is high enough and the specificity is high enough, and that's really where we've settled on 2.5 in this case, because once you get all the way over there to 3.75, the sensitivity is too low. You're going to miss too many people. So what's most important, look down at this alert time at the bottom. The alert time in number of days. This is a number of days that we were able to determine that this patient was going to ulcerate. So look at threshold number 1. That's kind of where we're settling. The threshold number 1, alert time in days, 36 days in advance. You can tell that somebody's going to ulcerate. And that's that asymmetry in temperature from a normal diabetic foot ulcer starts 36 days in advance. And you can get a warning and actually intervene at that time and do something. So, so now let's move over to the other side of the urgency pathways, and those are people that have active problems. And so we have all the way on the left there, if you get a hot spot from one of these cameras or from your home monitor, that's a UT. This is based on the UT foot ulcer classification. But also we should be using some other guidelines here, the UT diabetic foot, or the IDSA diabetic foot infection guidelines. Those are a little bit older. the International Working Group guidelines are fairly new, and also the Global Vascular guidelines are new. So these go into our calculation on how we're going to take care of these people with active problems. So let's go just briefly into the UT diabetic wound classification. This may be something you're already using. It really came out of UT because the Wagner classification was developed. It's still very popular in the United States, but the Wagner classification was developed for the dysvascular foot and not necessarily the ulcerated foot. And so at UT, we created a two-axis system where the ulcer is graded and then staged, almost like you grade and stage a cancer. So you have 0, 1, 2, and 3. This is based on depth. So 0, pre or post-ulcerative lesion that's completely healed or epithelialized. 1 is a superficial wound that doesn't involve tendon, capsule, or bone. So this might just be into the subcutaneous tissue. 2 is one that penetrates to tendon or capsule or muscle. It's deeper. And then 3, one that penetrates to bone or joint. Sorry. So then A, B, C, D are your stages, and the stages are uninfected. A is no infection, no ischemia. B is infected. C is ischemic, and then D is infected and ischemic. I remember these because they're in alphabetical order between B and C, infection and ischemia. So that's a good trick there. So when we look at the risk of amputation, cross-referenced with the UT diabetic wound classification, we can see that as your ulcer gets deeper or as it gets more complicated, that the risk of amputation goes up. And this is any level amputation, not just a limb loss. But if you have a UT 3D ulcer, in this study, there were 100% of them that had some level of amputation. So again, this is a good way to communicate with one another, but also to prognose what's going to happen with this patient. And all of these ulcer classifications have been reviewed, and this was a nice meta-analysis looking at the various ulcer classifications and whether they incorporated, they had validation mechanisms, and they incorporated all the aspects that we need for a diabetic foot ulcer. So now let's go into diabetic foot treatment algorithm. And we really focus on these key components. So we focus on vascular infection and pressure, do this first, and then debridement, promotion of granulation tissue, and closure once you've done the first 3. So the first 3, really infection is primary, but we put it in this order: vascular, infection, and pressure, because it's easier to remember, because we talk about the VIPs. And if any of you have seen, I don't know if he's listening, but David Armstrong get on an airplane, the VIPs always get on first, right? So we got to do the VIPs first. David gets on an airplane like a baller. He shows up in an Escalade at the gate, and I usually carry his bag for him when we get on the plane. But so your VIPs are always first: vascular, infection, and pressure. Then after you've mitigated these things, then you move on to debridement, promotion of granulation tissue, and closure. And the time between this might vary. Sometimes it can be very quickly, or even on the same visit. If I've ruled out a vascular issue, I've ruled out an infectious issue, I've managed pressure, I might debride right there on the first visit. So again, the timeline is not set in stone. It's that the order is set in stone. So I'm only going to, we don't have a lot of time. So I'm going to briefly touch on each of these categories and refer you to places where you can get more information. And you can always email me. I have most of these guidelines in PDF form, and I'm happy to email them to you. So on first, vascular, 2 clinical practice guidelines you should know if you're dealing with a diabetic foot. One is the Global Vascular Guidelines on the management of chronic limb-threatening ischemia. The nomenclature has changed. The global vascular societies recommend using the nomenclature chronic limb-threatening ischemia now, not CLI. PAD is still fine. PVD is no longer, but PAD is still fine. But chronic limb-threatening ischemia, and there's concise definitions on what that entails. But it entails any level of ischemia with any soft tissue loss. Even a clean ulcer is still chronic limb-threatening ischemia. Now, also the International Working Group, roughly around the same time, updated their guidelines on the diagnosis, prognosis, and treatment of PAD in patients with foot ulcers and diabetes. So in the global vascular guidelines, David Armstrong and I wrote about how to create a center of excellence for amputation prevention. We focused on the team, setting, components, and the function, and really teams made the biggest difference. If you look at all the data out there, the having a team, and your team can be virtual, doesn't have to be in the same location, but having a team made the biggest impact in limb salvage. So it's not all these different products and other things, some of which I may talk about coming up. It was having a coordinated team. And I would go even further and say, if you have a coordinated team and you already have pre-written policies and procedures and an algorithm you're going to follow, you're going to go even farther than that. So we wrote about this again just recently in the new Rutherford's vascular surgery textbook, which is coming out, these podiatric and vascular teams and the impact that they have. So those are your references. On the infection side, 2 clinical practice guidelines you need to know. One is the IDSA guidelines. Now, these are old, and I might even say too old. They were initially published in 2006 and then in 2012. It's a lot of work to get these things together, and I think that's why they haven't been updated. Those of you that sat on these guideline production committees, and IDSA is really busy doing a lot of other things, COVID and other things. So I think that these just haven't been updated in a while, but there's so much data out there now on other things, on using oral instead of IV for osteomyelitis, even for bacteremia and endocarditis associated with diabetic foot infections, that I wouldn't look at much of the treatment in those guidelines, but look really at the basis of the guidelines, and maybe the classification, which is very useful, was published in there, and descriptions of cultures and how to make the diagnosis. Those things are all still the same. Then the International Working Group recently published their guidelines on foot infections. These do, and of course we're speaking to an international audience now. They have a very international bend to them. The antibiotics that are in there are widely available internationally. So I would recommend reading that. A few things just to say. How do I diagnose a diabetic foot infection? This is a clinical diagnosis. In almost every setting, it's going to be a clinical diagnosis. You want to have swelling, erythema, tenderness, and warmth, or purulence coming out of a wound by itself. That's enough to make the diagnosis of diabetic foot infection. Laboratory tests are not definitive in the diagnosis of diabetic foot infection. So white blood cell counts, a study that was done here at UT, found that only 56% of those who came into the ER with moderate and severe diabetic foot infections had an elevated white blood cell count. That's moderate and severe, so not even mild. Moderate and severe, only 56% had an elevated white blood cell count. So therefore, you cannot rely at all upon the white blood cell count to determine whether or not there is a foot infection in somebody with diabetes because of an impaired immune response, immunopathy. Culture and sensitivity should never be taken to diagnose an infection. You diagnose the infection first, you take the culture and sensitivity, you take the culture for sensitivity to determine if you've guessed right and put them on the right antibiotic. A couple of keys on points on appropriate culture technique. First, here's the do's and the do nots. The do nots are kind of just opposites of the do's in their table. So I'll just read you the do nots, because I think a lot of us do the do nots, and we need to adjust our practice a bit. Do not culture clinically uninfected wounds. So if there is no infection and you did not diagnose an infection clinically, there's no surrounding erythema, there's no pus, it's just a wound, do not culture it. It is not that you're just going to grow surface bacteria. And what are you going to do with that result when you get it? It's going to be positive. You can culture your earlobe, you can culture your elbow. That's going to be positive. It's not infected. So do not do that. Do not obtain a specimen for culture without first cleaning or debriding the wound. So you clean the wound just with saline, not any type of antiseptic or antibacterial. Clean it with saline, debride the wound, take a good piece of tissue from the base of the wound. When we're in the operating room, I take a piece of tissue that's 1 cubic centimeter. and I send it to the lab. The lab told us they prefer larger pieces of tissue. So I find the most infected looking deeper tissue, and I take 1 cubic centimeter because they put it on all different kinds of plates, and they also save it in case we need to do something with it again later. So it's important to take enough tissue. Just swabbing is not enough. You can't just swab the wound. So, all right. And just as Dr. Wukic said, that when you're talking about offloading and pressure, it isn't only a medical problem, it's a surgical problem too. Infection isn't only a medical problem, it is also a surgical problem. We're going to run out of time. So, what I'm going to do is I'm going to skip a couple of things here. And so I know we can get to the questions. The next is pressure in the VIPs. And let's go to debridement real quick here. Debridement, the key I want you to understand here is that the frequency of debridement is directly correlated with the time to healing. The more frequent you debride your wound, the faster it heals. That doesn't always make, it doesn't make sense sometimes. I mean, physiologically, it does make sense, but if you're just thinking about, oh, I'm making this wound bigger every time I'm debriding it, but it heals faster. Well, it does, because you're removing all of the senescent cells and the other factors that biofilm, other things that are inhibiting wound healing. So in this study of 313,000 wounds, you can see that the darker bar is wounds that were debrided at 1 week or less intervals. The medium colored blue bar are wounds that were debrided at 1 to 2 week intervals, and then the lighter colored bar are wounds that were debrided at greater than 2 week intervals, and the time to healing is below. What do you see here? The darker colors are shunted towards the faster time to healing. The lighter colors are shunted towards the longer time to healing. So debride your wounds as often as you can. And we'll go to, so that's debridement. The next step is promotion of granulation tissue. There's no doubt that the negative pressure wound therapy is probably the most important tool that's ever been invented for wound care. It has been shown over and over again in studies to prevent amputation, to reduce the risk of infection, to heal wounds faster. But it's not, I'm here in San Antonio. It's the home of what used to be KCI and the VAC, which VAC stood for vacuum assisted closure. It's not meant to bring you all the way to closure. It's meant to get you to the next step, which is a level granular base. Then you move to the next step. Once you get to that point, you've already met your goals. You move to the next step, which would be wound closure. So dressings are, people get confused about dressings. I always try to simplify it. There's 700 dressings that are on the market right now. People probably come in your office all the time and say, you should use this, you should do that. Or like me, I go to my closet and there's just a whole wall of dressings. And I actually, first when I got here is I took almost everything out. It's just too confusing for everybody. And I put them into the main categories of dressings. There's only 7 main categories, and that's like, those are hydrogels, collagens, non-adherents, hydrocolloids, foam, what's another one? Alginates, if I didn't say that. So there's only a few categories of dressings. And if you just think about them in generic categories and say, what category does this one fit in? And what am I looking for in my wound? It's going to be a lot easier for you to think about what to put on it. I have a whole lecture just on dressing selection alone, which just simplifies everything in there. So now the last thing is just closure. So we're already down to, this is the last step really. And you're thinking about, how do I get to closure the whole time you're moving through the wound. Now I want you to think about the soft tissue reconstruction ladder. This was popularized by Chris Attinger out of Georgetown. And this starts from simple to complex. So we have something simple. We just let the wound heal by itself. Secondary intention. Now that's not always great. It takes a long time, but maybe that's all we have. So that's, or it's a smaller wound. We think it's going to heal anyway with good offloading and regular debridement. That's still secondary intention. Then we have what used to be called skin substitutes. Now we call it CTPs, cellular and tissue-based products. Then more complicated than that are skin grafts, and these are suction blister epidermal grafts, split thickness grafts, full thickness grafts. And more complicated than that, we have flaps. Those are random flaps, pedicle flaps, free flaps. The interesting thing about negative pressure is it's pretty much eliminated the need for free flaps in our patients. We can really close major defects just with VAC alone. So then on cellular and tissue-based products, I'm not here to tout any one over another. I'll just say be aware of the evidence that's out there with them. And there's different products that are on the market. These are all US-based approvals, whether it's prior market approval with PMA, 510K, which is based on a predicate device, or 361, which is based on human donated tissue, and what their actual indications are for, how many randomized controlled trials there are out for each of them. But really, I think all of them work pretty much the same, honestly. Whether it's a highly bioengineered or just some of these human amniotic tissues, which are pretty low level, not low level science, but just doesn't take much to get some of those and start a lab to do it. You just need one. So pick which one you're going to use, one that's easy for you. And I think that if you tried to compare any of them together, it would take thousands of patients to find a difference between any one. So pick one that's easy for you to use, it's available, and that's the one that you use. Last thing, skin expansion. This is another form of closure. We've been using this a lot. Infected wound underneath the first metatarsal head. After big IND, then we can use a skin expander. Oh, sorry, these two pictures in the middle are reversed. The skin expander should be there, then the sutures, then there's the patient afterwards. So I thank you very much. Happy to participate in the discussion afterwards, looking forward to it. And thank the committee and both groups, Diabetic Foot International and the Diabetic Foot surgeons, for inviting me.